It's Dr. Linda of the Vascular Birthmarks Foundation. I'm very excited to be with you this month, July 2020, and I'm very excited to have with us Dr. Christine Cazeau. She is a dermatologist and she is the USA Pierre Fabre Medical Director. Today's topic is how to treat hemangiomas. Okay, so Ilaha is on. I was going to say I don't see anybody on yet, but Elahe is on. So hello, Elahe. I'm so glad to see you. Today we're going to be entertaining any questions on the treatment of hemangiomas. You can see Dr. Cazeau. Say hi, Dr. Cazeau.
Hey, hi everybody.
And where are you right now?
I'm based in Scottsdale, Arizona.
So nice.
I'm at home.
Nice and warm, right, in Scottsdale?
Yes, very hot.
Very hot. As soon as the questions come up, I don't know if you can see the live stream yet. I'm looking for it on my phone as well. I'm not seeing. Did it pop up on your phone?
Yes, I have it.
Okay, yeah, I'm not seeing it on mine. I see it here. Oh, Savinji. Hi, Savinji. Savinji's on. Like I said, I'm still looking for, I see me in my test, but I'm not seeing our live feed yet on my phone. Nice to see you. Nice to see you too. Remember, any questions about the hemangiomas, please, you can share them now. I'm just trying to get my phone to synchronize with my computer. I'm not seeing it yet. Alrighty, it's okay. I guess I will just keep going until I see it pop up. Let's see. Hi, Christine. You're in. I see you're in too. So okay, you see us. So while we wait for people to come on, it says there's 7 people on. Why don't you tell us a little bit about the Hemangeol and what it does?
Yes, I'm a dermatologist. I'm a pediatric dermatologist, and I was trained in France. I'm working in the US for Pierre Fabre for 5 years now. I'm in charge of all the scientific and clinical activities related to Hemangeol, as you were saying, Linda. Thank you so much for the opportunity. The question was about how Hemangeol what is Hemangeol? Hemangeol is a pediatric formulated for a solution of propranolol, which has the indication to treat infantile hemangioma that require systemic treatment. This drug has been particularly developed for babies who are so fragile because you know that they are preemies and they are very small, and we have to take into account several aspects to give them certain medication. So Hemangeol was built to provide all the requirements that health authorities and also researchers take into account when you are talking about medications for babies population. So and that's how it was built, and several studies have been conducted regarding the pharmacokinetics, also the efficacy and the tolerance for the babies. So and that's how we end up having the marketing authorization from all the European Union, but also the FDA approval in 2014.
Thank you. So hello to Martina, and hello to Scott and Corinne. They're both on. We have 15 people on, and we're, any questions you have to, would like to add on. Hi, Ava. Ava is on. Ava is in our network, and she is an adult, and well, she's like 20 maybe, and she had face syndrome, and they didn't have hemangioma back then when she was, a baby. So I think her outcome could have been different. I know she's been treated by Dr. Weiner, and she's got a great result now, but the new gold standard of care, which is Hemangeol, has changed the lives of so many families. Hi, Eric and Eric and Ava. It's just, I'm getting the emails, and so is our advocate, director of advocacy, Corinne Barnaga. We're getting emails every day from families taking Hemangeol, just saying they can't believe it. Why did it get? Why did we not know about this sooner? Why did we have to wait? And I know that I'm just checking to see some questions. Hi, Jezebel. We are ready to take any questions on hemangiomas. Why does it take like some babies that have to get to be like 8 or 9 months old? Like, I wish we could do something. My goal has always been at the 4-week well baby checkup. If a hemangioma is starting to come out, then we should treat them and keep it from getting ulcerated and really, really large. But unfortunately, it seems like we're still doing a lot of catching up.
Yes. Yeah, it is unfortunate because if several studies have shown now that you have a specific window which is between 1 month and 5 months. That's when the hemangioma is growing the most, and that's the best time to start the treatment between 1 month and 5 months. So, it's sometimes too bad that babies are arriving to the centers a little bit after this period, and then when that happens, the outcome could be a little less great than what we could expect if we have treated them during this period. And then to help, there's a group of experts in different countries who put together a score for pediatricians to talk about, to help them to recognize infantile hemangiomas that could be at risk for the babies, and to recognize them very, very early, and then to let them know this baby will need to be treated. And if you have an expert center that is around, you could send the baby, refer the baby to these centers. Or if you have an expert physician, you can contact and guide you for the treatment, So this course is available online for pediatricians and primary physicians to help them when they are facing an infantile hemangioma when the baby is the first weeks of life, to help them say, okay, this is the location, this is the size, this is the number of hemangioma that we have, these are the potential risks, and it's a sort of algorithm that will help them to take the right decision at that time.
We have a philosophy too, like we don't make those algorithmic decisions, so we just say if it's there, go to a pediatric dermatologist and let the pediatric dermatologist make the assessment. It's the best call, is to at least get them to a specialist, whether it's a pediatric ENT that understands them, or a pediatric plastic, or a pediatric derm, but just get the infant to somebody that can do a more accurate assessment if they don't have that score. That's kind of like what we push them for.
Of course, but we are trying to put the score for all pediatricians, and it's available. We are seeing with the American Academy of Pediatrics to see if they can have it. Has a link on their website, and we are not there yet. But the score exists, and some pediatricians already know about it and are using it.
That's awesome. So we have a question. Ava wants to know, why do hemangiomas start out as a bruise and then get bigger?
So that's the normal cycle, I would say, of the lesion. So the theory that physicians think about infantile hemangioma now is there's something happening during the pregnancy or right delivery that we call hypoxia. So some kind of lack of oxygen that is the trigger for the hemangioma to start. In some babies, yes, you're going to have the bruise. In some babies, you just can have some kind of hypopigmented plaque that it's just a little pale compared to the rest of the coloration. And then after a few days or few weeks, that's when it starts growing, because all the blood vessels, as the tumor that is filled with blood vessels, all the blood vessels start getting together
Thank you. So that's the basic normal course of action. We have more people on. Tatiana, please submit your questions. We're very happy to answer your direct questions. Katie wants to know, what are the chances of a port wine stain birthmark on the back and trunk thickening and develop polyps? Or does this happen to facial birthmarks? I mean, I understand, like, so Katie, a port wine stain is not a hemangioma, even though a lot of times they use the term interchangeably. This discussion's for the infantile hemangiomas. We have, I mean, unless you want to answer the question, we do have on our website Dr. Nelson and Dr. Geronimus, who are our port wine stain experts, but these are progressive lesions and they can develop polyps just because the skin ages with these port wine stains. So feel free to email one of our experts unless you want to address this, Dr. Cazeau, about port wine stains getting thickening and developing they're blebs, not really polyps.
Yeah, I don't recall what is the percentage of these lesions that will develop the polyps as Katie is asking them, but that will not happen in all the babies, but it's happening with time, and for the chances probably to see with how you say that, to see with the other physicians that is dealing with these things every day compared to me.
And Tara had the same question. She's got the blebs on her stain on her trunk and back, and feel free to email me because too sometimes, Tara, it's not even a port wine, it's a venous malformation, and it has some of these small little blebs on it, and I'm working with a company right now on a new study regarding those. So please email me, Tara, and send me a picture. They'll post in this string here, but it's vbfpresident@gmail.com. Okay, so again, we're one question until we get some more. Tara is the last one. Chelsea is watching. Hi, Chelsea, and Katie. So we get a lot of questions and about 1 year old and their hemangioma is really massive. Is that too late to start hemangiol?
It's not too late because as there's a lot of diversity in infantile hemangioma in general. So in our label, it says that to start ideally between 5 weeks and 5 months. So that's the ideal time to start. But and what I'm saying is off-label use. It's happened when after 1 year or between 8, 9 or 1 month or 1 year old, the hemangioma is still proliferating. So there's some sign that you can see if the hemangioma is still proliferating. You can use the systemic treatment and Hemangeol use. But as I said in the beginning, the result may not be as great as it should be if it was treated between 5 weeks and 5 months. And of course, as I said in the beginning, it's an off-label use from here in the U.S. And because in my opinion, we had a compassionate use before Hemangeol was available. We had babies, at the time we didn't have all the data that we have now. We had babies that used to be treated after 1 or 2 years. So that happened, but it was in the previous stage. But now I think people are more and more conscious about or aware about the fact that these babies need to be treated early. And we are doing all the work to make sure that all the babies are getting the treatment at the right time.
Thank you. And approximately, what's the average duration that infant, if they're put on at a good time between 1 month and 6 weeks, around there, or 1 to 2 months, like what's the average time before you recommend to start tapering them off?
So normally the treatment duration is for 6 months. It's at least 6 months. The minimum you should treat, because at 6 months you're sure, 6 months of treatment you're sure that you're having a great result. If at 6 months the result is not there yet, the hemangioma is not completely melt out, you can treat for another 6 months, but usually you don't go to an entire year. So there's a Spanish study that has been conducted and published last year showing that if you start the baby within between 5 weeks and 5 months, so you can treat for 6 months and then stop. And then if at 6 months the result is not as great as expected, you can treat the baby until the baby is 12 months or 1 year. So 1 year old is the threshold when we know that, okay, yes, we can stop. Some babies will use, you can stop them at 9 months, 10 months, etc. But 1 year old is the time where we consider that we could stop the treatment for them, and we have the data for that.
Would you then, we get a lot of parents that are telling us their babies being put on the generic or whatever the beta blocker is at age 2 or 3, and we're saying to them that's really not recommended at that age. Have you addressed that some children at age 2 and 3 are actually being put on it?
Now, with the knowledge that we have, I wouldn't recommend that, because usually at 2 we are beyond the proliferating phase, so that's when we need to go to other treatments such as laser or surgery.
And another question that I have while we're waiting for some to come in, we have a lot of people on, so please, Sandy, hi Sandra, hi Lisa, hi Gabriella, you can submit your questions. Aaron, submit your questions directly to Dr. Cazeau. So what about the rebounding? We have some parents is that the rate of tapering that's happening? Like, why do some of them rebound, and then do you recommend they go back up in dose? Like, what do you do with the rebounding lesions?
It depends. Once you stop the treatment, you were talking about tapering. Let me address that. So normally you have the dose, which is 3.2 milligram per kilo per day, and as the dose is based on the weight of the baby, it's gonna taper itself, because while you will be giving the same dose, the baby weight is higher, so it will taper himself at the end of the treatment. So that's some physicians that the way they do the tapering. Others, they just keep the hemangioma until 1 year old, and then when they decide, they just stop it. They don't go through the tapering. About the rebound, now we know that between 10 to 20% of the hemangioma, so they will have what we call a rebound. But the rebound is single level. You can have just a recoloration. If it's a recoloration, there's no need to retreat. So we will evaluate 1 to 2 or sometimes 3 months after we stop the treatment to see if retreatment will be necessary. But not all of the hemangioma will need to be retreated, even when you have the recoloration, because the recoloration is just the vessel that are under the skin are just getting a little bit red, and sometimes it will fade away by itself, and some other time you may need to do a laser on them, but not all of them will need to be treated. The one that will need to be treated, the one that will have a regrowth of hemangioma, the thickness of the lesion come back. So it happens, but it's a very few babies that have of the population that has been treated when happen. So that these are the ones that will need to be treated.
That's very interesting. So what you're saying is the parents shouldn't panic if they see a little of the color getting darker. That may be just a superficial component. As long as the deeper part isn't growing, then that may be just a little bump in that superficial part, and they can ride it out and get a laser or just ride it out.
Yes, yes.
Okay, that's really important information because we do get a lot of those comments that it's starting to get dark. What do? Do we up the dosage? Do we go back to the doctor? But now you're saying the protocol is let's just see where this goes as you taper it. If the bulk doesn't come back, then we can just ride it out. And it's best maybe then to just get them off of it. Right?
Yes.
Okay, everybody, Kira is now on. We're ready to accept your questions. We have Dr. Cazeau, dermatologist, medical director for Pierre Fabre USA. And Pierre Fabre is the manufacturer of Hemangeol, the only FDA approved drug for the treatment of infantile hemangiomas. And this drug is the first line. It is the gold standard of care. I wish it was around 26 years ago when my daughter was born with hemangioma, because her option was surgery because she failed steroid treatments. And thankfully now the posts that we're seeing on all the hemangioma groups are amazing. Seeing the results of these babies go on it, I just can't wait for the day where it's just common every day for a pediatrician to say, oh, this is a emerging hemangioma, let's get the baby on Hemangeol, and it's just common everyday practice. And we'll know that because we won't be getting the questions anymore, and that'll be a good thing. It'll be a good thing that they don't need to ask us who is the closest doctor where they can get Hemangeol. Hi, Judy. So Judy is on. We're taking questions. So there's another question. Is Hemangeol universally available in the USA?
Universally.
Like all states? Does everyone in all states in the USA have access to Hemangeol?
Hemangeol is available everywhere. We have a central specialty pharmacy that can ship it anywhere in the country, but we also have partnership with pharmacy around the expert centers. So in some centers where we know that physicians there are treating infantile hemangioma, so we have in some of these places partnership with the pharmacy that is around the area, and they are stocked with Hemangeol, so the parents could get Hemangeol across the street. So yes, it's available everywhere.
I'm very happy to see, because I remember when in the beginning it was hard and expensive, and now it's like a regular copay. The work that you guys have done to make this accessible and available and affordable has been amazing over the last 5 years. And you know, you and I have talked about this, working state by state to allow families on Medicaid to be able to have access with this, and I know that's one of your goals and one of our goals as well.
Yes, and as you know, Linda, the company belongs to a foundation, and the fact that one of the goals of the foundation is to make sure that people can get access to the drug they need, and our foundation is working a lot on that. And because of that, we are doing everything that is in our power to make sure that all the babies who have an infantile hemangioma that require the systemic treatment to get access to Hemangeol once the physicians prescribe it. So once a doctor prescribes it, either it's going to be prescribed and they can start on the Hemangeol at the office when they have started bottles in the office. Otherwise, they will send the prescription to our specialty pharmacy that will send it directly to the home of the family. Or, as I was saying before, we can get the treatment at the pharmacies that the company partnering with that are around these experts. expert centers. Talking about the patients, the families that are doing Medicaid. So we are going state by state, and we have our team is working very hard on that to make sure that we can have Hemangeol available for Medicare and Medicaid patients. I want to say Medicaid patients. And so that's how we are giving all the information to the state's plan to make sure that they understood the need to have this drug available for these babies that are very small, very fragile, and that need to have a medication that is FDA approved, but it also adapt to their disease and has been studied, developed to specifically for this condition. So we are working hard on that, and we are getting some successes, and we are waiting for the others to come.
That is awesome. So let's talk a little bit about what is the most common side effects that you're hearing about.
The side effects that all the side effects that we see are expected from what we know from the drug. Usually it's mainly so the decrease of the heart rate, and that's why sometimes in our label it says that to monitor the baby at the expert center. So for 2 hours to monitor the heart rate, you may have a decrease. It's not a big, but it may not be seen, but that happens normally. But the heart rate could decrease a little bit by 7 heartbeat per minute. So it's not. There's no change. The baby stay the same. There's no change. In terms of side effects, what see is the coldness of the hand, the feet that will happen during the first doses. So the parent can experience that the hand of the baby is colder, and also their feet. As in our studies, what we saw is, as the propanolol is a beta blocker, we may have some, we are always at risk to have upper respiratory tract infections. So we may have an increase of infection. So if the baby is doing well, usually there's no need to stop the treatment. But if really the baby is not feeling good, usually we stop the doses and wait until the baby gets better to have them restart the treatment.
Thank you.
Another side effect I could think about is one of the precautions that is in our label is to have the baby get to feed the baby before or during give the medication during the feeding, or feed the baby and after give the medication, because there's a risk of propanolol to mask sign of hypoglycemia. So that's why it's recommended for the baby to have food before you give them the medication. So, but this is something that we recommend to all parents to be aware of. If the baby is vomiting, if the baby is sick, if the baby has diarrhea, not to give the medication at that time, but wait until the baby gets something to eat and keep it, not didn't vomit, to give the medication, because if the baby has an hypoglycemia, the medication can mask the sign that we usually see in hypoglycemia.
Yeah, these are really important things. We get a lot of, we see them on all the hemangioma support groups. My baby's hands are a little blue. What should we do? So you're basically saying that's typical with the first few doses, and they can just ride that out. Is that correct?
Yes, yes.
And that's why these Facebook Live videos are so important, and we'll be sharing this and posting it on all of the hemangioma group websites and on our website indefinitely, so the new moms that haven't even had their babies yet that will be having babies with hemangiomas, because even though we know how to cure them, we cannot stop them from being born. And I also say, babies with birthmarks don't care about COVID. They're still born every day with a vascular birthmark. And that's another thing. Is there any precaution with COVID for babies taking hemangeol, or any concerns or worries?
No, all the common sense precautions that are taken, that are required by the CDC, and that everybody's know about them now, but are the ones that family need to follow. Specifically for these babies regarding the COVID, there's not the treatment could continue unless the baby is safe and need to go to see a doctor or go to the hospital if there's something happening to stop the treatment. Otherwise, there's no specific precaution. The common precaution, wash your hands, and if you go out and then you come to the house and then it's the time to give the baby the medication, to wash your hands first and to give it to them, and not to have be doing something, because sometimes it happens in the families that the dad usually is the one who give it, and then the mom say that it's the time, and then she give it, and the dad didn't know that the mom was the
yes.
So and then to have this communication between those two parents to make sure that we are not giving the babies the doses, double the dose that she or he could just receive. So another way to do it is to have a little calendar on the fridge or on the wall where everybody, when the dose is given, to mark it to make sure that we are not double dosing the babies.
I can see Pierre Fabre on the Hemangeol page creating a downloadable PDF, nice colorful calendar sheet that the parents can print and then check it, because that's a big thing. Like, the moms are always saying, I don't know if my husband gave it or not. What do I do? Should I give it? So what's the answer if they don't know? If somebody, even if the moms don't remember if they gave it, should they skip it, or should they give it? Skip it?
Yeah. Because if the baby didn't get the dose, you can definitely get it the next dose. I prefer the baby to skip the dose and not having one dose instead of having overdosage.
Right. So, and then Danielle. Okay, good. So we have a question. Danielle McVicker. My 2-month-old has a mixed hemangioma on her soft spot up in the fontanelle. Should I get an ultrasound done to see how deep it goes? Do I need to worry about it putting pressure on her skull as she grows? Can it push things out of place?
I believe, Danielle, that the baby is getting treated. Usually you don't need...
No, she wrote to me yesterday, the baby's not on any treatment. She has a fairly raised hemangioma right over the soft spot. She's concerned about it going down through, and I told her it was superficial, but that's kind of what she's asking, how deep can it go down in the hemangioma?
Normally the hemangioma stay on the skin. Besides the hemangioma, that would be internal organs that are specific. Normally the hemangioma that you see on the skin, they could be deep on the skin, but they are not touching the other structure on the skull for this particular case. And if the hemangioma is big as I understood it has been described, then you probably need to see a specialist and to see if they could put your babies on the treatment that she or he will need.
Thank you. And I think it's important before we read Megan's question to say that studies have been done that untreated hemangiomas, only like a very small percent resolve without any residuum, without any like change in the skin, you know. So babies that have hemangiomas, like even on the scalp the size of a golf ball, I always say, think of a 300-pound woman who loses 150 pounds, half her weight, you're going to end up with hanging skin. So you're going to end up with this redundant hanging tissue if you don't treat, because so many people are still getting that leave it alone type of thing. But isn't it true that if you just leave it alone, it's not really going to go away? Not most of them don't.
It's you have it's gonna decrease the size. It's gonna but it takes years. I know we are talking about 6, 7, 8, 9 years for the hemangioma to go completely go away, but it doesn't. It practically never happen that you don't have anything else on the skin.
Right.
You should always have some kind of stigmata that a stain on the skin will require either surgery or sometimes laser and surgery. So, so far, when you treat, it's the only way that you can end up not having at all, to do anything at all, or only have to do laser when you're treating the right time.
In Dr. Weiner and Dr. Sun's book on head and neck vascular anomalies, it says 70%, and they believe it might be more, do not resolve on their own.
Yes,
so,
yes,
yeah.
yes.
So Megan has a very good question. She has had 2 failed wean downs of hemangeol. Diagnosis is diffuse neonatal hemangiomatosis, both times with significant regrowth and increase in liver hemangiomas. How long can Dominic stay on the medication safely? He also now is having low blood pressure, 80/52.
Thank you for the question, Megan. And I believe this is the type of hemangioma that we call that the ones that are very severe type, where the hemangioma, what the treatment is trying to do is to shortcut the course of the disease, because you have higher risk if we leave the hemangioma keep on growing than if you treat. So with the treatment, we are trying to shortcut the proliferating phase and then the plateau, and then after that the decrease of the hemangioma. So yes, it's unfortunate that you have to go through this, but I believe that when you fail the wean down, the physician start over again with the treatment, because the baby has less risk under the treatment than if you leave it with all the consequences that would happen. And the blood pressure, yes, this is one of the side effects that are expecting with the low heart rate, low blood pressure that could happen. So it will require to monitor the baby with blood most of the time. But once the way to manage that is to have a balance between the dose where the baby could stay on a acceptable blood pressure, and to make sure that we are doing something on the infantile hemangioma. And for this type of infantile hemangioma, which is really, really, really very rare, this is when the treatment could go over 1 year and more.
Now, I have a question too, because I don't know if there's a standard, but I don't think a uniform standard should be applied to weaning. I think you almost have to watch the hemangioma. And I've seen some weans happen over 2 weeks, and then there's a lot of rebounding. And I always wondered why, like with this case, why would you just do a super, super slow, like couple weeks, just cutting down a little bit, letting the baby kind of adapt, and cut down a tiny bit. Even if it takes 6 months to wean with a baby like this, wouldn't you kind of have a customized wean protocol?
Yes, of course, that's what I meant.
Yeah.
To have that's the type of baby when you're trying to have this balance, and then you need to keep it go for a long time, because you don't want you know that you can get the result, but you have to do it very, very slowly.
So there's another mom on. She's her name is Maggie. She said they have her son on Timolol, but it just hurts him. I don't know what. Oh, maybe rubbing it onto it maybe hurts.
Maybe it's ulcerated.
Yeah.
I don't.
We need more information from you, Maggie Gonzalez Hicks, about your baby that's on the Timolol. So that all the moms and dads with hemangiomas understand Timolol is a topical beta blocker. Hemangeol, is it only oral or is it also topical?
Timolol is it's a topical treatment for glaucoma, but as it's also a beta blocker, it's used off-label in some cases in infantile hemangioma. But all the experts and all the studies that have been conducted so far show that Timolol should be used only in very, very small infantile hemangiomas. So that means the ones that normally you wouldn't put any treatment, because they should be the ones that are less, 2 millimeters or less in diameter. So these are the type of infantile hemangiomas that Timolol is normally required. It's not an oral drug, as I was saying. It's a medication for the eye, but it's used off-label on infantile hemangioma, and then they use it in the skin. But it's definitely off-label, and it's not for oral.
So Megan, the one that has the hemangiomatosis baby, she said they went down by 0.2 mil over 6 weeks, and then went from 3.4 to 2.6, and then it drastically rebounded. So that I find that interesting. I mean, Megan, I'd like you to just email me, let me know, because I would believe she would be a case that would need to go to one of our real specialty vascular anomaly centers to see if there's some other options. I don't know where she is or who's treating her, but these complex cases like this sometimes need like a true multidisciplinary team to manage them. Like maybe, Dr. Adams or Dr. Bly, our hematologists, that are more familiar or have done a lot of these hemangiomatosis. Like you said, they're very, very rare.
Yes.
So,
and that's why I was saying, the dose between where you can stabilize and then you can decrease. In some patients, it's really very thin to find.
right.
And then if you have a too big gap between the dose before where it was working, and then you decrease it too low, and then you have the wiggle coming. So probably that's what happened, and probably that's when that's the finest dose to find between those two doses that has been used.
Well, also, the common sense, like to cut down by 2 mil and you go to 3.4 to 2.6 over 6 weeks, the baby's getting bigger. So, he's gaining weight too.
Yes.
And so he's kind of, with his own weight, tapering his own self at a bigger taper. So
yes. That's this aspect to take into account.
Yeah, you have to take that. So, Megan Wright, her baby's got a lot of pain. She says that it looks like, Maggie Gonzalez, that he can't sit because it's starting to ulcerate, and it's near his anus. He's 4.5 months. I don't know why, you can speak to this, but to me, it's out of the topical Timolol area, and he should be on an oral. Like, would you address that? I mean, it's ulcerating, it's near his anus, it's painful. He doesn't like when she rubs the Timolol on him, like that hurts him.
I wouldn't put Timolol for 2 reasons. First, because now we know that we shouldn't put Timolol in infantile hemangioma that it's really, there's a lot of side effects that could be associated with the absorption, even through the skin. We don't want the babies to have this type of side effects. That would be the low blood pressure or the low heart rate that happen in its topical treatment. And then putting it in a ulcerated infantile hemangioma could be even worse, because you have the blood vessels that are wide open and you are putting timolol on it. That I wouldn't do it. Instead, as you said, I would go for some wound care and having an oral treatment to help to decrease the infantile hemangioma. So that's what I would suggest.
Thank you. Megan is still talking to us, the one with the son with the hemangiomatosis, and I'm going to ask you to email me directly, Megan, because he's also been found to have what they call an AVM in his brain. So now we're talking about a whole nother syndrome, whether it's face syndrome or if it's one of our other rarer syndromes with hemangiomatosis. So Megan White, message me, email me, and I'm going to put you in touch with one of our expert physicians that really knows these complex crossover syndromes, because your son really needs to have a really good workup.
Yes.
And they're in Edmonton.
I am to do that because it's important to have a center where you have specialists of the disease that could help you manage, and have other specialists around that will do a multidisciplinary management for your baby, because that's what it is needed right now. And I'm glad that you are on the VBF, contact with Linda on the VBF website and Facebook page, because I think you can have good resources from there to help you find the best way to get better management for your baby.
And Maggie, who has the son with the painful ulcerated lesion in the perianal area, she's been going to Shriners, but I also need you both can message me on Facebook, Linda Roselle Shannon, send me a friend request, or it's easiest that way for me, so just email me, find me on Facebook, Linda Roselle Shannon, send me a friend request. That way I can open it up and get you into someone. And I don't know where you are, which Shriners you're at, Maggie, but again, that baby can't wait 2 months. She said it's going to be 2 months before the baby can be seen with that perianal painful lesion. We need to get you into somebody this week. Let me know where you are. I have no problem with calling one of our physicians to get you in this week if you're near Texas, or if you're near Florida, or if you're near Boston. We can at least get you and the baby in, or do a telemed with one of our doctors. They're all doing telemed, and at least okay, so you're in California, perfect. Actually, Corinne is on. Sacramento. We can at least get you a consult with Dr. Stuart Nelson. He's one of our experts, and he's in Southern California. Also in the Sacramento area, I can get you Dr. Alona Frieden at UCSF, and she's also an expert, current president of ISFA, and she's not far. She's at UCSF, so that's a good one also that I can get you to, Maggie. So I can give you her direct email when we get off. Yes, Maggie. So just message me, friend me, Maggie, and I will get you in touch with Dr. Frieden, and I will ask her to get you in this week, you and the baby, so that he doesn't have to suffer any longer with that perianal hemangioma. Again, you can see, Dr. Cazeau, that this is what we deal with almost on a daily basis, is the misinformation, the mistreatment, and the delay in the care is just unbelievable, that these people have to wait 3, 6, 8, 9 months. It's just an atrocity. So thank you for posting Dr. Nelson's information. But also email me, Megan, because Dr. Frieden is closer to you, and she can actually see the baby in the office at this time. So Dr. Nelson right now, because they're on kind of a lockdown where they are, they may only be doing telemed, but I believe that Dr. Frieden is seeing patients and her team. Yes, it is. She says it sucks how uneducated doctors are. I couldn't put it any better. I love it. It does. But that's why we're working together. We work with, and Dr. Buddy Cohn and myself, I identified 6 key areas with the AAP, and we accomplished all 6. Right now we're working on revising the Bright Futures little pocket guide that all pediatricians carry in their pocket to say if at the 4-week well baby checkup you see any kind of the birthmark, whether it's congenital vascular or a congenital nevus, to get them to an expert, because even though we don't handle those, multiple congenital nevi can be an indicator of an underlying condition that's often missed, neurofibromatosis or something else. So we're working on that right now. Maggie.
I would just like to emphasize the fact that it's important that having a foundation, or the Vascular Birthmark Foundation, to do, and other patient association that can help you guys that are online now, because we are talking about diseases that are rare, and pediatricians don't see them all the time, and it's really I have to say that it's a small part of their training, and sometimes they may have some difficulties to do the right thing at the right time. So, and that's why we are doing all the efforts that we are putting together to help them to be trained on this, and then help you to get to the specialists that could help with what you have as soon as possible.
Yes, and we take this battle very personally. I've been working with the past president of the American Academy of Pediatrics. We drafted the letter that went out to all insurance companies. We worked on updating the pediatric textbook. It went from 1 page to 38 pages. We did the webinar on hemangiomas, myself and Dr. Cohen. So we're committed and dedicated in a full partnership. And as I tell my families, if these doctors aren't trained in medical school to understand what these are, how can you expect them to understand them 10, 15 years into practice when pediatricians are looking for autism and other more common conditions that they'll see more frequently? So it's just a lack of information and education, and VBF exists to close that gap for the families and for physicians. We do physician education all over the world as well. So Maggie's getting the information right now. Our patient advocate director is posting information on here for Dr. Frieden, but also I will give you her direct email, and Maggie, and get you in this week. By hook or by crook, I'm going to get you in this week with that baby, so that baby doesn't have to suffer. That's what we do. We will stay up night and day to make sure that one child to us is all children. So that's very important to us. And again, we can't emphasize this enough. If a baby has a hemangioma and it's ulcerated, or the baby is in pain, uncomfortable, and they're not getting treatment, that's when we want them to contact us so that they can get into a proactive treatment center. It's going to take years. In my dissertation research, it says it takes 8 years in the medical field for a procedure to become normalized, routine. 8 years is the learning curve. And it was only 2008 when, a beta blocker was serendipitously discovered to be the proper treatment. And Hemangeol has only been FDA approved for, 5 or 6 years now?
5 years.
It's 5 years. So another 3 years, I think, of us with our joint efforts, we can get it to become more common and everyday. And that's why we exist, and that's why we work so closely with you. And we're just so proud of the work that you're doing, the outreach, that you took an interest in this orphan disease, because it is the very first, it's not just the number one FDA only approved one, it's the first time in history of infantile hemangiomas that anyone has said we need a FDA approved drug to treat these children, rather than all in the past when they used steroids off label, or when they used vincristine, a chemotherapy off label, even back when they used alpha interferon off label, and the kids had terrible side effects because there was never a labeled treatment. So that's why we're just thrilled to be partners with you. So we have 5 minutes left, and I promise you, Maggie, that I will be in touch with you. In the message, when you message me, give me your phone number, because I can call you in messaging. You don't have to put it on here on our Facebook page, but when you message me, just give me your phone number and I'll call you this afternoon. Also for Megan, so you're in Edmonton, Alberta. I'm not sure like who we have up there, but we were supposed to have the ISFA conference in Toronto, and that became a virtual meeting. I'm not sure, but email me, message me, and at least I'm going to put you in touch with experts that can answer your questions, and make sure that if there are some other options, because like I said, this is a little wonky with the AVM in the brain that he's already had, and the multiple infantile hemangiomas may need a workup for face syndrome. We don't know. But I want...
There's a big team in British Columbia for vascular anomalies. I know them well, but I don't know for Alberta.
If you can get me that contact information or an email of any member of the team, I could, yeah.
Yes.
That would be great. That would be great, because it's very common for us to have somebody with an extremely complex hemangioma, and literally 30 minutes from their pediatrician's office is a multidisciplinary treatment center, but they didn't know about it. So then they contact VBF, and we're like, 30 minutes is a big treatment center, and they're like, oh, our doctor didn't tell us. It's because they didn't know, because they don't know. You can't blame somebody for what they don't know. So as we're wrapping up, we have 3 minutes left. I mean, this has been very comprehensive, and I think our families are going to love this, because you've addressed a lot of the information you addressed, and I think you mentioned this, like when the babies spit up, to wait until they can take some food. Can they split the dose throughout the day? Do you recommend that, or?
Normally, within the dose, most of the time, we recommend to give the treatment twice a day. Some physicians, particularly when the babies are very small, they prefer to give it 3 times a day. So depending on the dose that the physician is prescribing, me, I'm fine with twice a day or 2 times a day. The only thing is, Hemangeol has been built to make sure that the volume that the baby will receive is always very small, and that's why it is very well developed for babies, because we know that there's a certain level of volume that the baby at a certain age shouldn't have. So the volume will never, it will be high, like maybe 5 milliliters, but for babies that are more than 8 or 9 months. But usually it's going to be less than that. So you don't need to split the dose that has been given, because it will be a very small volume anyway. So the only thing is to give the dose. You can put it in a little portion of milk if you want to have it that way. But usually it doesn't need, because the taste is very good and babies are loving it. It's a strawberry vanilla flavor, and babies really love it, and it has been tested to be adapted to, particularly for babies at this age. So usually you don't need to do that, but sometimes if needed, you can put it in a very small portion of milk or very small portion of juice. If you give it first, and then after that you feed the baby. So that's also something that could be done. But usually for the dose, you don't you don't need to split the dose. You just stick with the dose that has been given by the physician.
And the last thing, it's just a perfect segue to end, which is that so many mothers were in shock at how when they switched from the generic to the Hemangeol, the babies loved it, where before they were spitting it out. And some of the moms tasted it and said the generic was very bitter, but then this one has got like a strawberry banana taste, and it's really good. And that's important because babies can get reflux if it's bitter or not, and that's probably why a lot of them were spitting up, right? Because of the formulation.
Yes, because we have people who are using, because the adult solution of propanol that you were referring to has sorbitol in it, and sorbitol can induce osmotic diarrhea, and sometimes family don't understand why the baby is having, chronic diarrhea, but it's because of the sorbitol that has it, and some I have the example of some centers that they don't want to use the adult solution anymore because they were experiencing that with a lot of babies, and they are using Hemangeol, and since then they don't have the same problem.
Awesome.
Full experience.
Yes, thank you so much. It's been very informative, and we're going to share this with all of our hemangioma support groups. It'll be on our VBF website. We will get you the link to Dr. Cazeau. I can't thank you enough. Thank you to all the moms that have been on.
Okay. And I'm happy to help all these families. And if you have any questions, Linda can definitely send them to me. I would be happy to answer if you have other questions that come out after this live session. And thank you for the opportunity. Thank you for taking the time to hear me today and to speak with VBF.
Thank you all. Stay safe and stay well.